Thank you so much for joining us at the table. I know this is holiday week. I'm going to get started just to welcome everyone while the slides keep going. I just want to, of course, welcome everyone to our table today, whether this is your first one or one of many that you've attended. We've been doing these since January, and hopefully we've been getting a little better at them. This is our 11th one. We are not going to be doing one in December, so this caps off our year. This is a really, I think, a really timely topic for us, especially around mental health. For those of you who live IDD, you know that this is an especially difficult time with holidays, with lots of extra sensory and lots of people in the room and lots going on. And we know that we don't necessarily expect those hallmark moments. Um, I am Elizabeth Field and or Beth, and I am the program director for the Leadership Alliance for Neurodevelopmental Disabilities. You see the slide right here. We're right in the center. We are the backbone for Meet the Need NC, a collective impact initiative of which is funded by the North Carolina Council on Developmental Disabilities. You'll see that we do have guiding principles for getting together, not only with our advisory groups, but also with outside of our advisory groups. And we have recently started to move very actively outside our advisory groups to the IDD community at large. We had an IDD think tank, a policy think tank, the first part of this month, where we welcomed about 80 people outside of the groups we already have been listening to. We've got another slide. Keep watching us on our website. We have an email you can contact us on, and also we're on Facebook and Instagram. This is a slide I've been waiting for. November is National Family Caregivers Month, and we honor and we recognize our family caregivers, and we know that you are pulling a lot of that weight, as I am as well. Felipe, let's get started with our introduction about Spanish translation.
Absolutely. Thank you very much. Good morning, good afternoon, or good evening, depending on the time frame you're joining us from. Buenos días, buenas tardes, o buenas noches, dependiendo de qué zona temporaria se nos esté viendo. My name is Felipe. I will be your interpreter today, together with my colleague, William Salazar. Mi nombre es Felipe y seré su intérprete el día de hoy junto con mi colega, William Salazar. This message is to provide you with instructions on how to connect to interpretation, first in English and then in Spanish. Este mensaje es para proporcionarles instrucciones sobre cómo conectar con interpretación, primero en inglés y luego en español. If you're using a computer, you will find the interpretation option on the Zoom meeting control panel located at the bottom of your screen. If you want to hear the version in English of whatever someone says in Spanish, simply click on the small world icon that says interpretation, which is the same thing as translation, and then select English. If you're using a phone or a tablet, tap on the screen, and at the bottom right-hand side, you will see three dots that open more options. Tap on those three dots, then select language interpretation, again, same thing as translation, followed by English, and finally press the button that says done, and you will be ready to listen to the English interpretation during this meeting. Please remember that interpretation does not work on Chromebooks, or if you called in, you must connect to Zoom through the app for it to work. Lastly, I would like to remind all speakers today to please speak a little bit slower so that we can have time to do interpretation simultaneously. Thank you very much, and we'll be available for questions through the chat. Muy bien, las instrucciones en español. Si están utilizando un computador, encontrarán la opción de interpretación, que es lo mismo que traducción, en el panel de control en la parte inferior de la pantalla. Para seleccionar el idioma español y escuchar una traducción de todo lo que estén diciendo en inglés, simplemente hagan clic en el icono en forma de globo que dice interpretación o interpretation y luego seleccionen español. Si están utilizando un teléfono celular o una tablet, hagan clic en la pantalla. En la parte inferior derecha verán tres puntos que abren más opciones. Hagan clic en esos tres puntos, luego escojan interpretación de idiomas y luego escojan el idioma español. Por favor recuerden que la interpretación no funciona en Chromebook o si ustedes se unen a través de llamada. Tienen que conectarse a Zoom a través de la app para que funcione. Muchas gracias y estaremos pendientes del chat por si tienen alguna pregunta. Thank you very much, Mrs. Fields. Over to you.
Thank you very much, Felipe. It's very important for us to be able to take some time to remind ourselves that we are also very actively involved with our Hispanic and Latino populations here in North Carolina. We just don't say it, we do it, and we're trying to do that more inclusively. We also know that there are a lot of people in our Spanish speaking community who can't make it for the noon hour, and that we will have this recording available to them afterwards and also encourage their questions. Just a reminder, LAND is the group that is spearheading these webinars for Meet the Need North Carolina. LAND is an advisory group made up of solely of people with lived experience with, and that we define that as people with IDD or people who care for people with IDD, and that's mostly parents on this call. Meet the Need is a collective impact initiative to meet the service and support needs of the IDD community in North Carolina. We're acting as a driver of change, if you will. Just a brief update, you would have received your your October newsletters from our IDD Workforce Crisis webinar from last month. Like this month, it would have had our slides, a recording of the presentation, resources around our topic, and also, very importantly, a blog post from a person with lived experience. Please note as we mark the end of the year, we show gratitude for the help and support of so many from this year. And we will not be having a webinar next month in December. We'll see you in January after we take a 1 month break. We've got two amazing speakers today for this topic of IDD and mental health. That's Jill Hinton and Jennifer Mahan. We're going to follow their presentation with some comments from two people who are on our LENS Advisory Committee. That's the Lived Experience Network Speaks, and they'll speak to the topic from a lived experience perspective. I just wanted to first let you know a little bit more about Jill Hinton. It's actually Dr. Jill Hinton. She's a licensed psychologist, and she has over 30 years of experience working with people with intellectual disabilities, autism disorders, and mental illness. Dr. Hinton is a clinical director for the Center for START Services, where she provides consultation and training across the country, ensures clinical integrity in START practices and training, and facilitates a monthly practice group for START program clinical directors. During her career, she's worked with the Autism Society of North Carolina, the ARC of North Carolina, and Easter Seals in support of individuals and families. She continues to provide clinical consultation for NC START, which provide crisis intervention and prevention to individuals with developmental disabilities and co-occurring behavioral health issues. She works along with Anne LaForce to provide consultation and training on intellectual and developmental disabilities, autism spectrum disorder, mental health issues in people with IDD, trauma-informed care, trauma and grief in people with IDD, and a variety of other topics. She's earned her BS in psychology from the North Carolina State University and her PhD in psychology from the University of North Carolina, Chapel Hill. Jennifer Mahan joins us again. Thank you, Jennifer. Just a quick thing, a bit about Jennifer. She's Director of Public Policy with the Autism Society of North Carolina since October of 2010. Her role includes legislators, grassroots, and one-on-one advocacy supporting the Autism Society's public policy targets. Her 30 years of experience in health and human services have focused on consumer advocacy information and referral programs and public policy related to developmental disabilities, mental health, addictive disease, healthcare, and low-income benefits programs. She's also been involved with the Developmental Disability Consortium and the Public Policy Committee of the Coalition. Both of these women are extremely involved and interested in this topic today. I wanted to also say that our two panelists with lived experience today after our speakers present are RV and Marlene Cruiser and Diane Coffey. Please place any questions you have during our presentations in the Q&A box. We'll also be asking feedback during the webinar about specific topics and put those in the chat. The first question as we get started with Dr. Hinton is for you to put in the chat. For those with lived experience with IDD on today's webinar, have you had difficulty finding providers who understand both IDD and mental health issues? Put those in the chat if you will. We'd like to hear from you. And we'd like to introduce to you Dr. Jill Hinton. Thank you so much, Jill, for joining us.
Thank you, Beth. I'm really glad to be with you today. And Jen and I both have a lot of experience, and we've worked together, have known each other through most of those years of us working here in North Carolina. So I'm glad to be joined by Jen today. So I'm going to share my screen, and we're going to let me get this started. I'm going to try to do, and this is a big topic, but I'm going to try to do just a brief overview when we talk about intellectual and developmental disabilities and mental health. What do we mean? Kind of more from the clinical perspective and some of the reasons that it's difficult sometimes for us to get things together and present things in a way that we're able to provide support. And Jen's going to follow that with more kind of the system and what it looks like and what some of those barriers are, so that we can kind of cover both of those angles there. So often when we talk about IDD and mental health, I like to think about this from perspective of co-occurring diagnoses, and try to avoid this concept of there being a primary diagnosis. We think about things occurring together. We're all a whole person. So when we're experiencing challenges or mental health issues or cognitive issues, it's all part of us, right? We can't separate those into separate little buckets. So, and I know our system tries to do that, but from my perspective, when we talk about people that have mental illness needs, we're talking about a whole person. So we're going to talk about this as co-occurring. This could include things like medical issues too, that may occur at the same time. We do know, I put this quote, which people are like, why do you put a quote from 1983? But I think it's been long recognized that people that have co-occurring diagnoses within the system often face more obstacles to finding services and finding providers. And that's been true for a long time. I'm hoping and do believe that we've made some progress, but it's why we're here today, because there's still some challenges to that. So we know that people with IDD can experience the full range of psychiatric disorders that are experienced by people without intellectual and developmental disability. There was a time in our history that there was some thought that people with IDD didn't experience psychiatric illness for some reason. We thought somehow they were immune to it, but we do know that people we're all people. We can experience psychiatric disorders at any point in our life. Just like across the board, the most common mental health disorders that people experience, including people with IDD, are depression, anxiety, and the effects of trauma or stressor-related disorders. The things that occur far less commonly are things like bipolar disorder or schizophrenia or psychotic disorders. And they, like I said, are far less frequent than things like trauma, depression, and anxiety. So unfortunately, sometimes, and we may get to why this happens, is that in the IDD field, sometimes people jump to things like bipolar, schizophrenia, because they're not interpreting what they're seeing very, very carefully. So we sometimes see an overdiagnosis of those, but just it's always important for us to keep in mind that just for all of us, the more common things are depression, anxiety, and possibly trauma-related symptoms. So there's different estimates from research, but about 30 to 40% of people with intellectual and developmental disabilities will experience some type of psychiatric disorder during their life. That's compared to about 27% overall, just the general population. So you can see there is a higher risk for experiencing mental health issues. Of those 30 to 40%, there's a smaller percentage of folks who may present with challenges such as self-injury, aggression, that's really significantly affecting their ability to live day to day and to be a part of their communities. We'll talk about some of the reasons that happens, but one thing I always want to point out is sometimes we can say, oh, people can't communicate that well to us. But I think the reality is that in the service system, sometimes we don't listen well enough to what people are trying to tell us. So when I talk about aggression, I talk about that as this final common pathway that people get to. If they're experiencing psychiatric symptoms or medical symptoms, and we're not listening and paying attention, the people around them are not seeing those signs and symptoms, that sometimes becomes the only way somebody can communicate to us, because other things have been tried and we haven't listened well enough. So again, there's an increased risk for people with IDD to experience psychiatric disorder during their lifetime. Yet we know that that's sometimes missed, is sometimes inappropriately diagnosed, like I talked about earlier. Sometimes people misinterpret some symptom they're seeing and jump to some diagnosis like schizophrenia, which is not accurate. And then that can get you down a path of treatment, particularly around psychopharmacology or medications that take you down a path that is not appropriate. So again, sometimes we miss it, sometimes we misdiagnose. So that's why we're here today, to talk about what are some of those barriers and how do we try to address some of those. Sometimes it's harder to make that diagnosis just because people communicate differently and their symptoms may present in different ways. So we have to be very attuned to that. I didn't mean to make this like this, so I'm just going to go ahead and put it like this. Sometimes as I mentioned before, cognitive abilities or communication differences can sometimes make it more difficult for there to be an engagement between the person and the mental health system. So let's say somebody presents in an emergency room and the attending physician there goes through their regular list of questions about evaluating your mental status. And if you do that, you may be interacting with somebody who interprets language in a more concrete way than you do, who may answer questions in a very literal way. So, a common question that gets asked in a psychiatric setting or an emergency room is something like, are you hearing voices? And if you just take that at face value at a concrete level, everybody's going to say, yes, I hear voices. But somebody may not be understanding that you're asking about hearing things that aren't there or asking about psychiatric symptoms. The other thing, unfortunately, is that we've historically created a service system in intellectual and developmental disabilities where we focused on people doing what they're told, or I'm putting this in quotations, kind of being compliant and pleasing others. And so sometimes people just agree with things that people ask them. So again, we need to be attuned to these things so we don't misinterpret what we're hearing from folks, because it can result in things like somebody who's experienced trauma and maybe having symptoms from past trauma, and that getting misdiagnosed as a psychotic symptom and then going down another path. Or somebody who's extremely anxious and is unable to participate in things that they participated in before because of that anxiety. And sometimes that gets labeled as something like noncompliance, or it's seen in a behavioral way when it's really an underlying sign of anxiety or depression or something else going on. So I'm not going to, I don't want to spend, we want to have time for questions. So I'm not going to go through each of these really in detail, but you'll have this that you can refer back to. But we just need to be careful, like I mentioned before, in terms of how we interpret symptoms or signs that people might present with. And one big category of that is this concept of diagnostic overshadowing, where every time somebody presents with some type of symptoms, people say, oh, well, they have autism or they have IDD, and they're not paying attention to maybe somebody's presenting in a different way. Their behavior has changed dramatically, but people just attribute what they're doing to their IDD or to their autism, for example. And we miss underlying psychiatric things like depression or anxiety, or we miss a medical condition that might be going on when we assign things to that kind of primary diagnosis, like I talked about before. We need to be careful not to go down that route. And then there's other things that we need to pay attention to in terms of, I just mentioned things changing. So if somebody usually gets along in their day and presents in a certain way, let's say somebody who likes to tap their hands together, but we see that change dramatically in intensity or frequency, we need to pay attention to that. It's not just part of that disability, it's something that somebody's trying to tell us. I already mentioned with intellectual distortion around just being able to interpret what people are asking and understand the context of things. Always psychosocial masking is around always being aware of the developmental level that somebody is operating at from a social perspective, emotional perspective, so that we're not over-interpreting something. And then cognitive disintegration, that sounds like a horrible word, but basically just acknowledging that anybody who is experiencing intellectual disability or psychiatric symptoms, that stress can be really hard. So a stressful day can cause people to lose some skills they might have had in the past just for that day because they're really stressed. And we want to make sure that people aren't receiving diagnosis on their worst day. So this happens a lot. Somebody is having some challenges trying to communicate to us. They end up in the hospital. That's a really stressful place, or in the emergency room, a really stressful place that stresses any of us out, right? And then a diagnosis will be made based on how that person is presenting in that situation when they're under a lot of stress. None of us want to be evaluated, assessed, and assigned labels on our worst day. So we really have to be aware of the setting and how we're interpreting what we might be seeing with folks. So one of my favorite quotes from Dr. Jared Barnhill, many of you probably may know him. He was a medical director for the START team in the central part of the state, but also was at UNC, is now retired, but worked extensively with people with intellectual and developmental disabilities. But he always reminded us that having somebody say this person has a behavior problem is just like saying somebody has a fever. So if we have a fever that's lasted a couple of days and we go to the doctor, we do want the fever to go away, but we really want to know why we have a fever. What's going on under there that's making us have a fever? Because unless we treat that, we're not going to affect the fever. So thinking about when somebody presents and the system labels it as a behavior problem, that's just the tip of the iceberg. So that just, remember that we have to then think about what's below that. Is this person experiencing executive functioning difficulties and having trouble planning and needs more structure? Is this person experiencing anxiety And that's why they don't want to participate or go to work like they've been doing, or are they experiencing depression? Do they have trauma in their past? So always thinking about beyond what that externalized presentation is to what's underneath, because that's the only way we can be effective in supporting people. And with folks, with all of us, we want to think about when we're experiencing challenges, we want to think about our whole being, right? So think about the way we're presenting from a biological, psychological, and social perspective, and how these all contribute to how we all react and respond on a day-to-day basis. If we're not feeling well, we have some chronic pain or something's going on, that can affect our mood. We may be more irritable, may respond in ways that we wouldn't otherwise respond in. And we need to make sure that we're paying attention to all of those parts of a person when we're seeing them in a stressful situation or a crisis situation. So we know for people with IDD that they may present, let's go back to that aggression. Somebody's presenting with aggression because that's the only way they're able to communicate to us at that point. We have to think about all parts of this. So is there an underlying medical thing going on? Are they experiencing migraines? Do they have a toothache? Are they experiencing a urinary tract infection? We need to rule out all those biological parts before we move to anything else. Think about what that person's life experiences have been. Have they experienced stressful situations or trauma situations? What is their current living situation? Have they experienced a loss in their life? Maybe one of the people that has been a DSP for them for years has left and gone back to school, and they've lost contact. Those life losses and social effects can affect a person's presentation. So somebody presenting with aggression in an emergency room comes in one time, and it's related to them having a medical condition. Another time they may come in with aggression because we haven't figured out what else is going on. And it could be another thing. It could be that they've had a sudden change in their caregiving, and there's new people in their life and they're having a hard time adjusting to that. So always thinking about all of these as we try to interpret and help understand what somebody's trying to tell us about their mental wellness. So when we do that, I think one thing I always like to, when we're talking about IDD and mental health particularly, think about, and this will kind of lead into Jen talking about the system of support, is thinking about support and treatment. So when we think about people with IDD on a day-to-day basis that may need differing levels of support, that addresses some of those underlying differences in terms of intellectual and developmental disabilities. So things like providing visual supports, providing structure, providing help with daily living. Those are the support strategies that people might need, in varying amounts for longer periods of time. And usually for people with intellectual and developmental disorders, that's a little, that's a longer term. It may be less and more at different times in their life, but it's a longer term thing. When we think about treatment, we're thinking about getting access to mental health treatments that address psychiatric symptoms or mental health symptoms. Sometimes it's shorter term. We want to help somebody deal with a traumatic event that's happened to them. We want to get appropriate supports in place for treating depression, which may include some medication, but also include some cognitive behavioral therapy, for example. So we want to make sure we're matching the treatment to the need and matching the supports to the needs. And also recognizing that those two things interact with each other and don't exist in silos, which is kind of leads into what Jen will probably talk to us about, but that we've historically kind of, like I said, treated these things as, oh, their primary diagnosis is IDD, they're going to stay in this support category. And ignoring the fact that somebody might be experiencing mental health symptoms, and we also have to create ways that we provide treatment and have those things work together. So I'm going to hand it over to Jen. I know we want to leave time for questions too. But obviously this was a brief overview. There's a lot of things I could talk about in terms of IDD and mental health, but just being aware that it obviously exists in people with IDD. People experience mental health symptoms, and we need to make sure we are integrating the way that we provide support and treatment to folks. So Jen, I'll skip this, but this is just showing that we can make adaptations to evidence-based practices for mental health, that we can make adaptations to those so that people with IDD should be able to access mental health treatments within the community from counselors and therapists.
Thanks, Jill. This is the first time I think Jill and I have actually presented together, so this is going to be kind of fun. One of the things Beth might have not mentioned is that I spent 10 years working for the Mental Health Association in North Carolina, and have this sort of extensive background, not only in advocacy on the IDD side of things, but advocacy on the mental health side of things as well. So this has been of great importance to me throughout my life. We really in our system put people into these sort of separate categories and siloed off all of these sort of supports we offer, diagnosing people. All of this stuff is really sort of piled into separate categories. But as Jill mentioned at the start, they're a whole person. These things are all together and really need to be integrated and treated together as part of one person's system, but our system separates them. So we focused on habilitation in IDD. So those are those long-term supports and maintaining skills that people have gained. We also know people with developmental disorders do learn, they do grow, they do, their development trajectory may look different than somebody else, but they experience all of the same things that other people experience. So mental health and substance use disorder systems have focused on rehabilitation. So those are those treatment services, recovery services, shorter term interventions, sometimes though coupled with longer term but less frequent support. So we know people with mental health needs and substance use disorders are going to maybe have periods of time where they need more support, or they may need supports over a really long period of time. So this is just to say that I think we have much more in common between our sort of what we think of as behavioral health and what we think of as developmental than we actually have in different. And I sincerely wish our system treated things in a more integrated fashion. Next slide, Jill. So we do have a lot of systems challenges. The funding is separate. Our policies and clinical guidance often prevents people from getting integrated supports and services. Providers often only specialize in one particular area. They might provide mental health services, but not be familiar with IDD, or provide IDD services and have no understanding of anything going on in mental health or substance use. Our systems don't reward cross-training. So you don't get paid better as a provider if you gain more knowledge and aren't necessarily able to provide more enhanced services across these different areas. We have a few providers who offer some integrated, or they just happen to specialize in more than one area, but these cross-trained approaches are very limited and often only available in certain parts of the state, or available to a very limited number of people. Next slide. I focused a little bit in this slide on sort of the early intervention, but just recognize that these limitations in our system go across all ages. So there's a reluctance sometimes to diagnose people at an early age, both on the mental health side as well as sometimes on the IDD side. There's a lot of missed opportunities to spot things like autism, my brain just dropped out, other mental health challenges, trauma, to recognize certain populations are at risk, to recognize there may have been fetal alcohol disorder or alcohol use by the in utero. We have really limited early intervention programs if you don't get a diagnosis. So if there's some suspicion something is going on, but you don't get a diagnosis, you may go untreated for a very long period of time or until much later on. And I see this a lot, especially with mental health populations who don't get an IBD diagnosis, sometimes until much later in life, in that transition age or in adulthood, especially with autism being diagnosed alongside some of these mental health issues. And then IBD populations who have, we recognize that they have behavior problems, but as Jill pointed out before, they might not get an actual diagnosis. That behavior problem gets attributed to their IBD rather than addressed as something that relates to depression or anxiety or other underlying problems. Next slide.
And Jen, I'll just add real quickly, I gave that 30 to 40% of people with IDD experience mental health challenges, but we do know also with autism that anxiety is co-occurring much more frequently than that, which is sometimes missed.
And I think we miss sometimes that the experience of being an autistic person generates tremendous amount of anxiety in terms of the sensory overload, in terms of how you might experience the world. So sometimes you get an anxiety diagnosis, but there isn't a recognition of how much of that has to do with the way you might experience the world and your neurological differences. So sometimes you see the anxiety being treated without recognizing that you have to maybe look at the environment the person's in or look at other things that are going on rather than just saying, oh, the person has anxiety, let's treat that. So you've got to take a much more integrated approach to these things, and that's really what's lacking in our system.
Jen, I'm sorry to interrupt,
Yeah.
but just that ties back to when the slide with the biopsychosocial. Not only do we need to evaluate from that perspective, but we need to develop strategies from that perspective, right? That include all of those. Yeah.
100%. So challenges for families, individuals, and sort of general community. There's still a lot of stigma around all of these diagnoses. It's unfortunate, it's there. So we often see people not wanting to be labeled. I get it. Because of the stigma, you don't want the label, but without the label, it's sometimes difficult to recognize what's going on and get appropriate interventions for it. There's enormously long waiting lists for a lot of services, not just the innovations wait list that we talk about a lot. We have a lack of adequate healthcare coverage for most people. We're finally getting Medicaid expansion in North Carolina. We're hoping that that will open up healthcare coverage for people who didn't have adequate healthcare coverage before, but there's still a lot of gaps even once that program goes into place on December 1st. The system is way too complex to navigate, and it is definitely not integrated. And the mental health of both family caregivers and family support people and the person with IDD aren't addressed. I think we maybe recognize the issues of family support and family caregivers needing good mental health support. We often sometimes don't recognize that there's really two people or more than one person in this situation who are experiencing these challenges in different ways.
Thank you so much for saying that, Jen. I think that gets forgotten. And as you're doing this year over year, we need to look at the family as well.
Absolutely. Next slide. So I want to just point out that the impact of the waiting list isn't just a lack of services for the person who has intellectual and developmental disabilities. It means that they may not be getting access to other services and supports that they need. Waiting that long and having a lack of supports is a mental health issue. It worsens people's outcomes when they don't get supports early on and when they don't get some kind of behavior interventions early on. Being left out of community life worsens your mental well-being. That is absolutely the case. And I think we don't do enough to recognize the impact of that on folks with intellectual and developmental disabilities. Transition age youth in particular will see other their peers and other people going on to college and employment and independent living and starting families. And they aren't getting the supports and services in place to allow them to do similar things and do things that they want to do that their peers are able to do. And then we really, in a lot of ways, infantilize a population by not offering services and supports to them. So they are left in this sort of dependent state for a very long period of time when they may be looking for and wanting to do other things in their life. And of course, again, the mental health of caregivers and family supports, that's been likened to, in some cases, the PTSD that's seen by combat veterans. I don't want to exaggerate that in any way, but that is an actual quote that over a long period of time without supports of family members and family caregiving can be incredibly difficult and affect mental well-being in the long term. So next slide. Results of this is our system requires a primary diagnosis. This is an artificial construct. This is something that we have made up, the idea that somebody needs a primary diagnosis, because the only reason we've done it is to be able to slot somebody into a set of services or a set of funding and then sort of ignore everything else that they need. So most of these children and youth that we were talking about who are in ERs or are being boarded and don't have some sort of placement have complex needs. When I say complex, it means they have overlapping intellectual and developmental disabilities and mental health or substance use disorders or other behavioral disorders that make finding the right treatments and supports for them difficult. Why is that? Just what I said before, lack of providers who understand these complex needs and a lack of funding, structuring our funding in the way that allows us to pull different pieces together into one integrated support system for them. They might need a waiver slot plus behavioral health supports, but if that waiver slot is not there and they're just getting the behavioral health supports, that's not going to help in the long term. All right, next slide. We have a lot of opportunities in this system. A lot of opportunities to create change by making our entire system IDD and behavioral health informed. Talk a lot about trauma-informed systems, which I think are incredibly important, but we have an opportunity here to make our systems more integrated and more sort of cross-systems informed. We can focus on early intervention with at-risk populations to make sure that they are less likely to need those supports later on. We can remove funding silos. We can ensure that our crisis systems, and that's not just police and mobile crisis, but things like 988 operators are trained on IDD and autism. There's a lot of emerging research in this area that suggests especially folks with autism present in crisis differently than folks who don't have autism. So I think it's really important for folks to get training. And we can end the wait list for IDD services, as well as expand eligibility for Medicaid to ensure that children get supports and services at an earlier age. It's my soapbox, last slide. We would love to hear what you think the system should do, what barriers do you think are in place, and what suggestions you have, because of course we want to pass those on to policymakers and see where we can make, and we have such an amazing opportunity to improve our system and remove these silos, and we want to hear from you.
And Jen, I'm just going to reiterate and reemphasize something that you've alluded to as you went through, is that we also, I mean, we're in a reactive mode often, especially for people with IDD and mental health needs. We're reacting as opposed to being proactive and ending the wait list, getting people the right supports, making sure they have a sense of belonging, meaning in their life, not isolated. Those are all what we all need to have meaningful lives. And I think that goes such a long way for all of our mental well-being. And that's why these things work together and why we need to have the end of the waiting list, which is what this group is is working toward, but that's part of our mental wellness, right?
Absolutely. I mean, that's 100%. If you take anything away from today, it's that the wait list isn't just an IDD problem, it's a mental well-being problem.
Right, right.
I love that you both are saying that, Jen and Jill. And this has been a fantastic presentation. I know that many people have asked. It will be available afterwards. Our presentations, our slides, and extra recording as well is in our follow-up newsletter, and this will be available after Thanksgiving. I wanted to just, before we go to questions at large, there are two people with lived experience from our Lens, our Lived Experience Network Speaks, who are with us today. RV Kuzer and his wife Marlene, as well as Diane Coffey. And I'm hoping as we our clock ticks down to the 1 o'clock hour, maybe both of you could give us a couple minutes on RV and Marlene. From my perspective, I think that you have very vocally talked about living with both a mental health diagnosis and an IDD, and you have you are older within this community, so you have seen this change over time. Do you have any hopeful notes for those of us who have children who have both of these that are co-occurring?
Thank you for having me today. I really appreciate that. Marlene and I are honored to be here. I think primarily, for me, I never knew about services were available my whole life. So putting aside that everything that I'm dealing with, I didn't know anything about the system. I didn't know that I could be possibly eligible for getting assistance. It was never discussed. So I think that a greater link to individuals to understand what's available for them would be a great start. And I think that the children are empowered by being with other children, and not so much children that are like them, but also that are not like them. I found my experience as a child, it was very give and take, and we would learn from each other, and primarily we would learn how to excel a person's ability on how they perceive things. We see everything differently. Thank you.
And RV, from our discussions and within the Lens group and otherwise, I think that you also didn't have those labels in those early days that say that we have now. So did you?
Oh, of course. Back in the 1960s? Sure.
Okay.
It's the R word.
Oh, yeah. I hear you. Thanks, RV. I'm going to ask Diane now, from her perspective, and I've asked her either from the family she serves or her own personal perspective, if she could talk a little bit about some key takeaways for us today.
I think the largest takeaway I could probably say to families in general, coming at this from a parent that, has a child that has the co-disorders we're talking about here today, is you're not alone. Their families, there's other families, we're all out there in this together, and making sure you think in that context. You're not the first or the last to face what you're going to face. I know some days when I've faced some of my worst with my son, some of the suicidal pieces, and that it just, you feel like you're the only one, and it's so hard to balance that and move on and do what you need to do for the best for your child. So I think just really being intentional about reminding yourself you're not alone, finding those connections. Everything Jill and Jen have said today is so true. Those pieces around others not knowing, you as a parent know. You know what your kid's doing or not doing. You know what's normal for your child, and you know what's not normal, what's changed. Speak up, share that, find somebody that can help you. And there are people out there. A lot of times it's another family member quicker than it is a provider sometimes, because we can find other family members a lot of times quicker than a provider. Realistic piece of what we're facing today is family members can help each other. And that's, I guess, the strongest thing I could say is help each other, be there for each other.
Thank you, Diane. And with your work, I know you say that repeatedly to the families that you work with. Thank you both for your advocacy.
Can I just say something, because Diane kind of took the words right out of my mouth. Is that it just so happens that Arby has a session with a counselor later on today, and he did find one. It was, it was difficult, but you have to keep on, like she said, keep on, keep on trucking. Okay, I'm old. Keep on trucking. All right. And just, move on. And if you can't find one here, go to another one, and you will find one.
And you two have been married for, I think, 36 or 37 years, which is an inspiration to all of us parents.
Thank you.
I'm going to pull from two different, just 2 or 3 questions, because we're getting to the end of things. Just remember, if we don't get your question, we will put them to Jill and Jennifer, and they're wonderful about answering questions afterwards. But I think that the one for actually both of you, Jill and Jennifer, is we've had repeatedly people say, where do you find a provider who can do both of those things? And by the way, Jill, can I use you as a consultant for a family? Where do you find these people? And I'm telling you, personal experience, it's very, very difficult. Go ahead.
I think what Diane said is that to me, the families are the place that know they've experienced different providers and therapists and community folks. I think some of the family groups are the best place to find. I mean, I can give you just a name of a few therapists I know that have done this work in the community, but I think in each local community, I think that, and Jen, probably through some of the parents that work for you all, Jen, that is where you get the real information about who is open to working with people with IDD, and who has spent the time to develop some skills and to learn about it, and who will work. I think the other thing is really key is somebody who is going to work with you all as a family, right? Because individual therapy for people with IDD is not often successful unless it's paired with thinking about the broader context, and who's around that person, and how do we create consistency in how we're providing that support.
Yes. So
yeah, Jenny, I don't know if you want to add to that. Go
your
ahead.
local support group, even if it's just an online version. So an Autism Society offers support groups, there's Family Support Network. There are other, Down syndrome support groups around the state. There isn't one in your area, get in touch with one of the organizations I mentioned and talk to them about making connections in other ways. Some of them may have virtual support groups or other Facebook groups you can join. We have a pretty extensive list of folks who work with folks on the autism spectrum, not so much folks with other needs. So I will just throw the Autism Society out there. Your LME MCO should be able to tell you who is working in your community who has some expertise in multiple areas. I know that information isn't always as extensive as people would like, but I would encourage you to put some pressure on your LME MCO to make that information available and to utilize their funds to train and support providers who work across these disability areas. That's a big piece of the puzzle.
Thank you both. And one of the main reasons LAND got started a couple years ago is because there are parents who couldn't find resources like these. So there's one more question that we'll get to, and then we'll say goodbye for today. But this is the issue around, is there any form of therapy that does not focus so heavily on language comprehension and verbal language? We've had that question a couple times.
So a couple of things. I mentioned, I think I mentioned cognitive behavioral therapy, but a subset of cognitive behavioral therapy is DBT, dialectical behavioral therapy, which can be broken down into some usable strategies around emotional regulation and kind of helping people with that. So there are parts of that that can be pulled out and used for folks who may be less verbal. The other thing, which I hope will become more available at some point, and there's emerging literature and research around, is EMDR, eye movement desensitization and reprocessing. That's a lot of words to say, but it is something that doesn't rely as heavily on verbal narratives or telling your story or those kind of things, and has been shown even with people who are nonverbal. Some of the strategies, I don't know how much people are familiar with them, we can't go into all the details, but there's some bilateral stimulation that happens around eye movements or tapping, and has been shown just some elements even of that just again helps with some emotional regulation and helping people to just be calmer and have less of the externalized behaviors. So there are ways to modify several of the evidence-based practices for folks who have less verbal skills.
That's great. And we'll have the list of questions that we weren't able to get to, and there are a couple more like that for you.
One more thing, Beth. The other,
Go for it.
The whole system thing is that there is also research showing that if you do mindfulness training with staff, if you do nothing else with anybody else, but do mindfulness training with staff, it greatly reduces like behavioral challenges and incidents and things of the people being supported when we also support the staff that are supporting people.
I would throw family in there too.
Yes. Yeah.
Big
Absolutely.
Proponent of mindfulness training for everyone.
Yep.
But yes,
we hear you, and as we get ready for the holidays, that's very important. Yeah, as we get that's very important for those of us who sit closely with IDD. I'm going to say thank you to everyone, and then I'd like Cheryl Powell to leave us with an act. Just thanking everyone, our speakers, all of you today, and also our translators and our interpreters, and just everyone who makes this possible. We're going to meet again in January. Look forward to your newsletter the first week of December, which will have the recording and slides and answers to your questions, etc. And I'll just say, take care of yourselves and be well. And Cheryl Powell, if you could please leave us with an act and also a final thank you and goodbye.
Yes, ma'am. And thank you everyone for being here. I did put my question in the chat, went to put it in the Q&A, and it won't let me, but you guys will see it, or I'll pass it on in an email. I know you guys. But the ask is, number one, next meeting, bring someone you don't know with you. That's how we get the word out, okay? That's ask number one. Ask number two is for something for you all to just be considering. How do you see yourself within your organization, within your individual lives? How do you see finding common ground as it relates to you, your organization, the people you interact with? I just want you to be thinking about that. If you have questions, you have thoughts, email one of us. We're glad to hear from you always. Thank you so much to Jill and Jennifer and RB and Marlene and everyone that participated. We think so much of you and the work you're doing. We care about you and we want you to be a part of what we're doing. So thank you. Happy Thanksgiving, everybody. Please take this time to enjoy yourselves. And with that, I'm going to set you free. So thank you again.
Thank you, Cheryl.
You all.
Absolutely.